Dr. Gerald Pfeiffer and I, we just finished the wonderful edition of the Allegheny Health Network program that is on every Monday night in conjunction with Highmark from 7 until 8. Right now, we are re-airing the Pat Toomey, Katie McGinty debate. So if you tune in for that, that's what you'll hear. And make sure that you join me after the debate for all of the post-debate coverage. We're going to give you a chance to phone in and give us your thoughts. But also, John Delano, KDKA TV2 money editor and political analyst, will be on the disc to the Pittsburgh Newsline. So stick around for that. And of course, we have CBS Radio News at the top and the bottom of the hour. Biggest sports story trending today with Jeff Hathorn, our sports director, who is bringing sports updates every 20 minutes on The Fan. And then, of course, on News Radio 1020, KDK's Afternoon News with Mangino and Duffy. Big Ben meniscus. I had a meniscus tear. I took about 3 weeks to recover, but obviously I'm not a professional quarterback.
Oh, you're not?
I'm not, even though I play one on the radio. Realistically, what are we looking at, Doc?
Yeah, I think 3 weeks is a realistic time frame. They play the Patriots, and then they play then they have a bye week, right? After that, and then they play the Ravens.
Right.
So he might be ready for the Ravens. I don't think he's going to be ready for Sunday.
Now, minimally invasive surgery, and obviously what that means, arthroscopic surgery, and they talked about cleaning up as opposed to actually repairing the tear. What does that mean?
Well, there are two types of things you can do with a meniscus. Well, actually three types. You can take the whole meniscus out, and that's what we used to do whenever we would go in and do a meniscectomy. Or you can take the part that is torn and clean up that meniscus so it isn't rough and possibly cause arthritis in later years. Or the meniscus can be repaired, actually put sutures in it so that it can heal. But it really depends on where the meniscus is torn. The meniscus gets its nourishment partially from a blood supply, but only about a third of the meniscus is supplied by a blood supply, all the width of the meniscus. The rest gets its nourishment from the synovial fluid, the fluid in your knee. So if that tear is in where the vascular part of the meniscus, that can be repaired. You put stitches in it, it'll heal, but it takes longer than 3 weeks. But I think what Ben had was a cleanup, where that torn meniscus was just removed, that portion that was torn was taken out.
How much problem can scar tissue cause, especially if the knee's been repaired more than once?
Well, scar tissue really isn't a big factor whenever you do things like arthroscopy and so on, because you aren't going to get scar tissue within the knee itself unless sometimes there's an infection that may occur. Then that can cause some scar tissue within the knee. But very seldom are you going to find scar tissue within the knee.
40 years as surgeon of orthopedic medicine, one of the best in the city of Pittsburgh, and I can attest to that. He's operated on many of my friends. Now you're retired, but still the host of this program. And one of the things that I've seen by watching the Allegheny Health Network grow and evolve with Highmark through the years is the Allegheny Health Network Orthopedic Institute with Dr. Patrick DeMayo and his fine staff of physicians, including a friend, Dr. Edward Schnell, to where they really specialize in this stuff now. Let's talk about where knee surgery and traditional surgery, when it came to repairing a joint or some sort of tear, as far as a tendon is concerned, when you started, or maybe 20 years into practice to where we are today, and how far arthroscopic surgery has advanced sports medicine, but also orthopedic medicine.
Well, sports medicine was just coming into its own right around the time that I started my resident in practice in 1970. It was just about then that sports medicine was becoming somewhat of a specialty. And now it is a very, very big specialty. In fact, there are subspecialists within sports medicine. There are people who only operate on the shoulder. There are people who only operate on the elbow. People who only operate on the knee.
The hand.
The hand. So those things have really changed. When I first started in practice, I was a general orthopedist. I did a little bit of everything. And today, you have these subspecialists. But as far as the knee is concerned in arthroscopy, I can remember the first arthroscopy we did. The scope had a little glass light bulb on the end of it. Sometimes you'd break it off, and so you would have to go in and take those little pieces of the lamp out. You know, it was amazing. A doctor by the name of Dr. Watanabe, who used a cystoscope in the first arthroscopy, which is cystoscope is what you look into the urinary bladder with. And that's what he put in the knee to look around with that scope. And so now the scopes are so much smaller, and so you need a very, very small incision, like a quarter, 3/8 of an inch to get that scope in. And the visualization is just absolutely incredible. And then you have some magnification. When we used to make like a 1-inch incision and go in, and just with the naked eye, we go in, the visualization and the illumination with arthroscopy is 10,000 times better than doing it the old way.
If you look at this type of surgery, whether it be called latch key surgery, keyhole surgery, arthroscopic surgery, whether it's putting stents in the heart, or whether it's doing some sort of cleanup around a joint, to me, it is advanced medicine light years, and the real reason is because of recovery time and also that threat of infection, which hospitals do an amazing job to keep people safe, but it's just a part of what they do, and it does happen. But when you make a minimal incision, it really helps the process as far as healing, right?
Absolutely, and so much of it can be done as an outpatient. When I
Surgical
first started
centers,
in practice, I mean, we admitted patients for a trigger finger or for a carpal tunnel. Now that would be blasphemy if you admitted a patient for something like that. But so much can be done. But what people have to understand, it's still surgery.
Yep.
There are still risks involved, and even though it's called minimally invasive, not necessarily minor surgery. Minor surgery is sort of defined as if it's happening to somebody else, it's minor. If it's happening to me, it's major.
Right.
So it's still major surgery. There are risks involved. There's a possibility of infection, or possibility of other things going wrong, and so on. But those are very, very small percentages for those things to happen.
Before you go, we had a very important program tonight. Dr. Shivani Dougal, Dr. Casey Moffett, and Dr. William Pollard were on the program. Breast cancer was the topic. It's Breast Cancer Awareness Month. We mentioned Ben Roethlisberger. No one does more to help the color pink. And of course, the whole idea of breast cancer than the National Football League. I think we all took away one thing tonight. We even heard from a survivor who's 81, who developed breast cancer over 4 decades ago. And that was a great way to end the program. But the key is to get regular mammograms and self-examination.
Absolutely. And there's no reason in the tri-state area why any woman has to not have mammography, whether it's financial, whether it's social, whatever. A lot of it is just they don't want to do it because they don't want the radiation. As Dr. Pollard said, it's like flying to Denver. There's no more radiation than you would get in an airplane at 30,000 feet between here and Denver.
I have to ask you this to close, because Dr. Pollard was actually questioning the class tonight, talking to his amazing doctors, and one of the things that we talked about was technology and how far it advanced. And you and him and I have been at this a long time. He is a broadcasting news physician, and doing medical frontiers through the years, it has obviously advanced. What do you think is the biggest advancement as far as treatment of breast cancer today as opposed to even 10 years ago?
Earlier diagnosis, better techniques with diagnosis and with biopsies so that you know whether or not there is a cancerous growth within the breast, and then better surgical techniques in removing that tumor, better chemotherapy, better radiation therapy. All of those have advanced remarkably. The woman who called, who was 81, she had radiation therapy and she had burns from that because the radiation therapy used today is so targeted. It goes right to where the tumor is and not the entire chest. That's why she had some burning.
Ladies and gentlemen, every Monday night, don't miss it. They were the first to do it as far as media and broadcasting, bringing you regular healthcare programs. We've been doing it for close to 3 decades on News Radio 1020, KDK. Dr. Gerald Pfeiffer, every Monday night at 7, the Allegheny Health Network, in conjunction with IMARC. Good night.